This chapter deals with attention deficit hyperactivity disorders. Early in my career, that term didn't exist. We often talked about hyperactivity. Later we talked about attention deficit disorders. And finally, in the later stages, when I was actually instructing in college, the term ADHD became important. It is a condition that is difficult in some senses to define. What we have now is a system in which we declare a student has one of three types of attention deficit hyperactivity disorder. And you'll read about those in the chapter. Lack of attention, a hyper-movement oriented type, and a mixed type. You'll also determine that we have very little idea about etiology. We know it's a condition that's associated with inheritability. We also know that it's a condition that has some association with teratogens encountered prenatally, for example, alcohol, and one of the concomitant conditions with hyperactivity is often fetal alcohol syndrome. But we can't identify precisely those causes in the vast majority of cases. We also know that there are some physical, anatomical conditions associated with ADHD, brain size differences in anatomy. However, those aren't consistent, and we often see students who have different kinds of electroencephalograph profiles, and all of them have some part of ADHD symptomology. Finally, the diagnosis of ADHD is, as we refer to frequently, clinical. It means that there are no hard signs of neurological impairment. There are no blood tests or specific kinds of instruments that we can use to positively determine that that is the case. We rely on the reports of teachers and the reports of observation and the reports in a variety of environments about students' typical behavior. In ADHD, we have moved to consideration of how well students control their inhibitions, how well they can control their reaction to various stimuli. And that's probably the most important thing to consider as you look at the whole phenomenon of ADHD. We, for example, cannot tell if a student lacks the ability to control their responses or whether or not they attend to appropriate responses, or whether or not they use executive functions to redirect attention appropriately. So, as you read in the chapter, look at the way that you see students or children acting in your environment and see that it is possible for, at any one time, two different people to see the same behaviors in different ways. The other thing about this chapter that probably engenders the most controversy is the use of drugs to treat the condition. There is a standard treatment for students who have ADHD, providing them a psychostimulant, Ritalin, which is chemically related to methamphetamines. Paradoxically, it appears to assist the student in controlling their behavior. However, scientists who study the phenomenon don't believe that what you are seeing is a paradoxical effect. What they think is that brain function is mistimed. It is at a tempo inappropriate to the stimulus around them, and that psychotropic drugs seem to make the brain fit more in sync with the tempo required. It's a controversial topic because we're fairly sure that psychotropic drugs are oversubscribed, that ADHD is often misidentified, mislabeled as because we can find instances in schools in which certain teachers have an inordinate number of students referred. Other teachers have very few students referred, so we know that context often determines diagnosis. You're going to see a number of learning implications for ADHD, including the ability to redirect, the kind of attention that you should be paying and should demand from students, and some ways to engender that. Look at contracts, contingency-based management, and also look at how one can engender, assist students in developing executive function and impulse control.